Welcome, everyone. So we're going to get started. Good afternoon. So I want to welcome everyone to the Religion and Public Life Center's Religious and Civic Leader Gathering today. I'm Todd Ferguson, and I'm the director of the RPLC here, and I am so thankful you're here with us today. So our theme this year has been leading communities in the midst of change. And we've had some amazing conversations this year about various topics. And so, as you can see from the slide on the screen, after today, we've got two more to round out our season. We've got one more that's going to be virtual, and that's going to be with Ryan Burge on March 9th. He's a professor at the Washington University, St. Louis, and he's going to be talking about the changing landscape of religion in America. He just published this book. I don't know if you can see my screen. It's okay if you can't, but he published The Vanishing Church, How the Hollowing Out of Moderate Congregations is Hurting Democracy, Faith, and Us. And so he'll be joining us. That's going to be our second virtual one. And then we're going to round it off in May at the Cohen House at Rice. And we're going to talk about faith leadership in complex times, insights on Houston's collaborative capacity. And so we're going to have our very own Kirby Goff, Elaine Howard Eklund, and Rachel Schneider with us. And so that will be in person on May 11th. So today, I am so excited. So today we're going to be talking about how religious leaders can respond in a mental health crisis. And so we're pleased to have Dr. GLEN MILSTEIN with us today. GLEN is a clinical psychologist and an associate professor of psychology at the City College of New York, part of the CUNY system. And as we'll hear today, he's the creator of the COPE model, COPE, which stands for Community Outreach and Professional Engagement. It's a model that helps create this continuum of care between religious leaders and mental health clinicians, and to make sure that people under our care have that continuity. Glenn earned his PhD at Columbia University, and he completed his clinical training at Bellevue Hospital System. Glenn was recently a visiting scholar at the University of Cambridge's Faculty of Divinity, where I was fortunate when I was in England to go visit him at Cambridge, and it was amazing. A lot of his work has been published on really helping mental health clinicians gain a better understanding of how spirituality impacts clinical care. And so he is like one of the leading researchers in this idea of connecting spirituality and clinical mental health care. And so, Glenn, thank you so much for being here. I know we're all virtual, but I'm going to clap. So thank you so much for being here. So Glenn, I'd love to just to
Yeah,
start it with a broad question of like, how did you get here? How did you get
right.
where you're studying as a clinical psychologist, the connection with spirituality, religious leaders, and then the connection with mental health clinicians? I'd love to hear that.
Yeah, you've got the funny we have a you can study cultural competence. You can do a whole range of studying cultural competence. And one of the astonishing things that happened is the field of cultural competence came along and doesn't talk about religion.
Mm.
Ethnicity, culture, all these, it's really amazing. And I was a Peace Corps volunteer in the Dominican Republic for 2.5 years, and I worked on with families building houses. And in this small village, there were 9 churches. I also spent a year studying in Jerusalem, and just the centrality of devotion across, so many different traditions, still organizing people's lives. And I also had chances to travel, and one of the constants of human experience is religion. And That I was very aware of, that I was very interested in. And I was working with an anthropologist, a psychiatric anthropologist. He was studying what it was like to be a caregiver of someone with serious mental illness. So we were interviewing families, and I'll refer to this in the talk. We interviewed a mother whose son had schizophrenia, and we asked her, "Do you think your son's illness will ever be cured?" And her answer was, "Si Dios hace la obra, aunque los médicos dicen que no." If God does the work, my son will get better, even though the doctors say he won't, because it's a illness of the brain, it's a chronic, lifelong malady. And there was just this kind of immediate awareness of how they were missing each other. She wanted anything to help her son, and clinicians want anything to help a person. And here is this whole resource that gets her out of bed in the morning to help her son that we don't get trained in.
Hmm.
And then when you take it another step to public health and you realize that the biggest challenge that mental health care has, that physical health care have, our biggest challenges in medicine are diabetes and other chronic conditions, and in psychiatry, dealing with depression, schizophrenia, anxiety, things that are chronic. Well, clinicians can treat acute problems, but we can't live with you, right? We're not your community. And there are, in the United States alone, over 370,000 religious congregations, which from a public health perspective is doors to knock on to talk about continuity. It's the biggest need that the people I worked with in psychiatric hospitals had was community. And many, many, like most people, were connected to some religion, either growing up or currently, or were looking for a different place. And there was a woman we did a presentation who said, I left my church for one point, I was away, I sort of needed time alone. And then when I was ready, I kept going to churches and nobody said hello. And finally, I found a church that gave me a solid welcome, and I found community. And we can talk a lot more about from a public health perspective, all the resources that exist at one church, synagogue, mosque, temple after another, from a public and public mental health perspective.
Yeah, so say more about like your story about like how when you were
So,
training
yeah,
and
so I'm in graduate school and I have to decide on a dissertation topic. And that's when I met this mother. And I actually still have a copy of my notebook page where I wrote down quickly what would a bridge look like? How would we get the two to talk to one another? What would that um and I disobeyed the number one rule of a doctorate, which is I did not do my mentor's work. You really need to, if you want your thesis done quickly, you pick up a piece of what your mentor's doing. But I really wanted to know, was there traction? Do clergy and clinicians even know about each other's areas? Would a clergy recognize a mental illness compared to a religious problem? Would a clinician be able to differentiate someone frozen by mourning and grief that was not depression? And so we did it was a nationwide survey of rabbis and psychologists, and it's since been done with imams and Christian clergy, where we sent vignettes of different kinds of stories, um, and asked how serious the problem was. And so to differentiate, you had um, a young man comes home from college and isolates himself up in his bedroom, and he's seeing angels. And we asked, is that serious? And one rabbi wrote in the margins, we go straight to the emergency room. In other words, who does this? They knew, the clergy know, they're experts, right, in the people in their communities. On the other hand, at the same time, clinicians, when we said a young man's father died and he needs a ritual, a way to mourn this, immediately recognized the unique role of clergy that was not their role. So they understood the borders of their different domains. And the problem was that they didn't know how to talk to each other. There might be a clinician who knew clergy somewhere, and there's certainly clergy who know a certain number of clinicians. But to actually get people thinking, get mental health clinics to think of, to ask about the importance of religion in someone's life, or to ask whether or not a congregation was a resource, just hadn't been trained. And so
Mm.
the work over the last years has been to um, reach out to communities, but also partner with colleagues of mine who do training of clinicians to ask about religion and spirituality. And other colleagues who go into congregations and do training about how to bridge and connect to mental health care. Um, and what we now know, as I mentioned a little bit ago, is you don't live in the clinic. We've got an epidemic of loneliness and we need community. And so, both how do we help religious congregations be stronger communities and give themselves credit for that? And how do we help clinicians see that resource? And for both clergy and clinicians, how do we help them know it's okay? You don't have to do it all. And you don't have to build anything new. That's the other thing. If we reach out to these resources, we've just saved billions of dollars of trying to make new infrastructure. There was a important book called Bowling Alone that talked about the problem of isolation. Well, for the majority of people in the United States, religious congregations have been and are part of their life and could be. And we'll talk about the caveats, the things to worry about in that, the ways to be careful in that. But these are extant resources that really just need a bridge.
Yeah, so why is that bridging, that collaboration between clinical care, congregational life, why is that not happening? Like, where's the disconnect there?
The disconnect is silos. The disconnect is so you have an extreme in both domains, right? Um, you have within um, clinical psychology and psychiatry, um, some folks being completely dismissive of religion as anything but, um, a distraction or worse. But it's a group and it's a voice that gets repeated a lot. But it's really not, most clinicians just never hear about it. We learn all about ethnicity. We learn all about sexuality. We learn about a lot of things to understand the variety of the ways that humans are, and religion just isn't taught. So we don't know. And we interviewed clinicians in Sweden, um, and they said, we know we're not religious, but we know about religion. We don't ask about it because we feel so ignorant, we're afraid. Right. So I would say that's where the vast majority of folks are. They'd love to, they just don't know how to. That's on the
Mm.
clinical side. But similarly, on the clergy side, on the one extreme, there's plenty of patients who've said, I had to leave my church because they just kept telling me to pray harder. They couldn't acknowledge me as having depression. And there's other religious folks. There's a book out there called Psychoheresy. And there's a whole conspiracy theory that Sigmund Freud's whole purpose in life was to destroy religion. And therefore, all psychotherapy exists to undermine religion. A more nuanced view came from a pastor who I spoke to about this, who said, look, I'm a shepherd. How can I be confident that you'll treat my sheep right? And mostly that just requires a vocabulary of respect. He's not asking me to share his beliefs. He's just asking me not to challenge the religious beliefs of folks he would send to me just because. Now, I don't rule out that I'm going to ask if there's negative aspects of someone's religiosity or religious history. Because as we'll talk about, religion's powerful. That's good news. That's also bad news. Because as we know very well, it can be a source of profound trauma. So we don't do it because we haven't been trained. We haven't built the suggestion into the system.
Mhm.
Whenever we do it, people kind of flow into it. On the other hand, there is no budget item, and this is true about all public health and all prevention, where you're getting people to talk to each other before a problem, or you're getting a problem to not resurface, right? If I can get you connected to community, your depression, it'll take much longer for your depression to come back. You can sustain recovery. That's true for substance abuse too. Problem is, where do you put a budget line item for money saved? Right? The hardest part of what I do, what public health does, is says, I need you to spend millions of dollars. And they say, great. What do we get for those millions of dollars? And I say, you are so lucky. If you spend this many millions of dollars, I can promise you that you will achieve nothing. No depression, no schizophrenia, no measles, no cholera, right? If you spend millions of dollars to keep the water clean, there won't be cholera. You spend millions of dollars on prevention, then you won't have to spend tens of millions of dollars or hundreds of millions of dollars on treatment or higher levels of treatment. So that's the other huge difficulty in helping people to see a system where mostly they just see what they do and they don't realize there's this continuity. When we talk about it, we all get it.
Mhm.
But then you got to try to fund one person in a clinic to be the bridge builder to congregations. Um, and the doors they knock on are already built. And the inclination in most congregations to help already there. And also somewhere an acknowledgement that well-functioning religious communities are doing a ton of prevention work just by being who they are.
Mhm.
So people just don't yet have all that vocabulary.
Yeah. And
Does
so,
that answer what you asked?
no, that's great. That's great. And so um, so our group, our audience, our religious leaders, civic leaders, those who are leading some sort of community.
Right.
And I would love to know, like, from your view as a clinician
Yeah.
and a trainer of clinicians, what can religious leaders do when, let's say, they see someone having a mental health episode in their care?
Hmm.
They are not clinicians themselves, but they're spiritual leaders, they're community leaders.
Absolutely.
What can they do? Like, walk us through that process. What's a
Okay.
good approach?
So I'm gonna suggest you tell me I can go straight into answers or I can hop over to the slides. And now we're gonna backtrack a bit because I'm gonna give us some foundational stuff, some background, and some very Houston-centric background. Because I didn't get a chance to, first of all, say thank you very much for this invitation. And while I wish I were there, I can tell you that, as you'll soon see, Houston is a huge, only, it is only in Houston that the foundation of what I'm going to be talking about to begin all this starts. Because the biggest challenge, right, is for us to see people first as people, and then we can start layering on identities. Um, we're very good at doing us versus them. It's a lot harder for us to do us and them, which, by the way, Todd, is one of the answers to your questions. I can see myself as a psychologist, and I can see them as religious organizations. To see that my patients go to that church or my patients go to that mosque or synagogue, I don't necessarily think about, because when they're better, they leave. If I inquire, suddenly I'll see the connectedness, and that the clinician isn't just, I'll send you to the clinician, then come back. It's all part of a continuity. And one of the largest stigmas out there is toward people with mental illness. It's much less than it was 50 years ago. But we have this struggle, we've got this challenge of how to see our connectedness. And Houston annually celebrates one of the best examples of that. So I'm going to share my screen. Is that what to do here? And let me just tell me, can you all see the slide? Okay, so here we are. And I'll do so we got about 20 minutes to run through this, and I'll get exactly to the question you asked and some others. How religious leaders can respond to mental health crises. Let's get over here. Yeah, so simple fact, we've got an epidemic of loneliness. The Surgeon General reported on it. We have people who are feeling isolated. We are living right in an atomizing world. We all have this little computer in our pocket, and it's got a screen, and it's got a business model that needs our eyes on it, right? Which means we're not listening to each other. And so if we could get religious organizations to recognize how what you do is an incredible public health donation, and then realize what the continuity is. So there'll be 4 points today. We've got this epidemic of loneliness, and a lot of people who are suffering come to their clergy. They seek help from their clergy. And the good news is that clergy and congregations are mostly prepared. You already provide a sense of belonging, and when people have a challenge, you give them connection. And if we talk about grief as the paradigm here, you're already set up to do what I would call an intervention, and you would call being who you are. And then if you're there to provide a solid welcome for folks, they can find a place after treatment. But clergy and congregations could use collaborators, because there are acute needs that are not treatable in a congregational setting. And so how can you build a bridge, learn, connect to what mental health resources there are? And the thing that is really not talked about is that clinicians need collaborators. Everything we've just been talking about. The first thing we need to do is understand that all of it has to do, with one humanity, right? There it is, folks. And this is one of those moments where science and certain religious traditions and almost every kind of origin story says that humanity started right in one place. Can you all see my cursor? So this is the biology. We've done the genetics. We've run it backwards. That's it. 23andMe was a lot of fun, but it did a lot of damage because it didn't tell you the bottom line, which is that there's really one place you're from, right? We're all from Africa. We all started in one place. And whatever it is that happened 300,000 years ago, we started asking why. And we also started trading with each other. And so when you look at the earliest settlements, you're going to find evidence of commerce, right? A bead made out of a shell from 100 miles away. The other thing you're going to find wherever you find humanity is a sacred space. And these have been organizing us as we have traveled across the planet. There is an inherent worth and dignity of every person, because every person is every person. And again, I've worked with people with very serious mental illness, and it's really the language of theology that in many ways speaks to what they're experiencing, this sense of loss, this sense of isolation, this existential dread. So how do we do it? How do we actually get this balance going where there's one humanity? It's great intellectual, but we belong to groups. We have spiritual and cultural specificity. When I was at Cambridge, there was a chaplain of one of the colleges who said, look, I am here, and you can think of this as the chaplain's balance. I'm here to help everybody, just like any chaplain in the military is there to help everyone. And yet at the same time, I have my own, as he said, I'm a company man. Well, it also turns out that many religious traditions have this idea. This is the Hebrew is B'Tselem Elohim, the image of God, that there is a unifying principle that we share. And it's just that, that phone and its business model doesn't work well if we're thinking about how we're all the same, right? It only generates revenue when it generates eyeballs, and it's conflict that does that better than anything. So how do we get here? How do we get to this place where we feel comfortable with our specificity and comfortable with the universal? Because that's what's going to be necessary for a congregation to welcome someone who's got a mental illness, who's got certain attributes that aren't everyday, yet is a human willing and wanting to participate. So it's the chaplain's balance, right? Every chaplain has to figure out how to do that. Military, hospital. Turns out it's also the astronaut's balance. And it started, the example we're going to give was from 21st of July, 1969. What happened that day? I can see most of you weren't around, but what happened that day? Throw it up in the chat, unmute yourself. Oh, somebody can chime in. What happened that day, folks? Go ahead, Todd.
The moon landing.
Right? And right in that era, Dr. King reminded us that our scientific genius had made of the world a neighborhood, right? That was when we first could look at the whole planet, a photograph of the whole Earth, and really see this little blue marble. And he reminded us that it was going to take a different genius to make us get along. And these three men got it, each in different ways. Neil Armstrong, the first person to set a foot on the moon. Buzz Aldrin soon after. Michael Collins, waiting for them to get back off that moon. And they're in Houston every year on the Sunday nearest the anniversary of the moon landing at Webster Presbyterian Church. They celebrate the Lunar Communion Sunday, which some folks like to call communion. I didn't make it up. And this is why. Buzz Aldrin, who grew up in the church, who was an elder Presbyterian, knew he was going to land on the moon, and he wanted a way to acknowledge that. And so he met with his minister at the Webster Church, and they divided up bread, and they put into a Ziploc a little baggie wine, and they gave him a silver chalice, all of which he took on the moon so that he could do communion on the moon and at the church in Houston. They would do it at the same time. And he taught us something that day. So this is the 3x5 card of what he was going to say to folks. This is the LM pilot. I'd like to request a few moments of silence. I would like to invite each person listening in wherever and whomever he may, wherever and whoever he may be, to contemplate for a moment the events of the past few hours, to give thanks in his own individual way. Mine shall be by partaking of the holy elements of Holy Communion, of the elements of Holy Communion. And this is what he actually said. Can you all hear this?
Willie, you can go ahead. This is the GLEN. I'd like to take this opportunity to ask every person listening in who contemplate the events of the past few hours and to give thanks in his or her own way. Over. Roger, tranquility base.
What's different than what he planned to say? First of all, he realized that he might as well talk to both halves of the planet and his or her own way. And can you all hear me? Okay. In his or her own way. And he left his own rituals for himself. That somewhere in the awe of that place, I'd like to think, he really, I mean, you know, if you can only imagine, what would it be to sit still and know that every human who could is listening to you? And what would you say to them? And in that moment, having written down one way on the left, he actually made it even more universal in the moment. That's the chalice that was handed to him at Webster Church. Just a little, you know, if you can hold your fingers like that, about 3.5 inch. And his own prayer for himself was from John 15:5 and Psalms 8:4 and 5. I am the vine and you are the branches. Whoever remains in me and I in him will bear much fruit, for you can do nothing without me. When I consider your heavens, the work of your fingers, the moon, the stars, which you've ordained, what are we that you be mindful of us, and the Son of Man that you visit us? What I want to do simply is note, he did not stop being who he was while acknowledging the totality. There's very few of us who can acknowledge so much totality. And yet it's right there in Houston that one of the best examples I've ever heard of or thought of or saw happened. And so I'm very grateful to share this with you all, especially because it's that open heart that you need to make a congregation that can give a solid welcome. And it's that mindset that we need to teach the clinicians so they don't need to be afraid of someone's own faith. And then here's it in another set of words.
After the flight of Apollo 11, the three of us went on a around the world trip. Wherever we went, people, instead of saying, well, you Americans did it, everywhere they said, we did it. We, humankind, we, the human race, we people did it. And I'd never heard of people in different countries use this word we as emphatically as we were hearing from from Europeans, Asians, Africans, wherever we went. It was, we finally did it. And I thought that was a wonderful thing. Ephemeral, but wonderful.
So well within our capability. Well within our capability to not be threatened by thinking of our shared sanctity, which are part of the skills needed to do this work, to do this bridging. So again, why do I advocate to my colleagues that we need to talk about religion? Because it's present across humanity. It influences emotions and behaviors. Right? I'm speaking as the psychologist. Now, that's different than any kind of conversation about whether or not a religion is true. That's not what we're talking about here. We got people in pain. We want to help their pain. And whatever their vocabulary, that's where we go. And we ignore too much of human existence if we ignore people's religion, spirituality, faith. As I said before, good news and bad news. It's supportive of those who find affirmation. It's painful when people feel the connection is lost, and we need, as clinicians, to know if something's been lost and if there's pain. And religion can be detrimental when there's rejection or denigration or ostracization. To answer your question, Todd, I do this because there's fewer, more powerful psychological variables than religion and spirituality. It's dishonest to not try to know. And this is what I had said to you. This was the woman who said to me, si Dios hace la obra. And there was another young man with schizophrenia who said the biomedical model of mental illness has contributed significantly to our understanding of major mental illness, but little to true recovery. Right? So what does he need to feel like he has true recovery? While medications may help one's behavior become more acceptable to society, they do nothing to put one's shattered soul back together. So as I said to you, I need to train clinicians on how to use religious vocabulary because that's how people are experiencing it in their own lives. Mental illness. I can give you words like delusions, hallucinations, paranoia. You or a family member with someone with serious mental illness is watching them become someone else. And for centuries, the question has been, is God visiting this on me? What did I do wrong? We need to engage that vocabulary. We need to engage. Again, it's not the clinician who gives a theological opinion who says, oh, no, God wouldn't do that. However, it's a clinician who wants to ask and inquire and understand and perhaps partner with clergy to help us do the best work we can. Right? So we've developed this framework where we can build bridges across our domains to do treatment, sustain recovery, and also acknowledge what's already being done. Right? So the first answer, Todd, to how we help people with mental health problems is do what you already do. Right? Every religious congregation celebrates, gives people a sense of belonging, welcomes infants, sanctifies partnerships, has songs and what some of my clergy friends call smells and bells. Except what that does for us in the pews is not secondary. It's what gives rhythm, and for a lot of people, it gets them out of bed. And getting you out of bed is one of the best things for your mental health. let alone being connected to other people, let alone feeling, and this is really crucial, feeling that you're being generative, that you are contributing to others' well-being. And the thing about a congregation alone is it can provide just a little something for someone to do. I might still be suffering and not want to be around people a lot, but if I could stand at the back of the pews during services and then run down and set up the coffee for after and then go home, I'll have been an adult. And there's very little in my life, if I have serious mental illness, where I get to be an adult. I go to day treatment programs. People ask if I'm taking my medication. Being able to be generative is a hugely positive thing. It's what we all want. It's what we all need. And the other thing that happens already is one of the other expertise of clergy, along with celebration, is to respond to suffering. You know, and some have argued that all of the movement to find the scientific support for religion and, oh, here's the data that proves it, and here's the other thing that proves it. Science is its own thing, and it's very narrow. The formulas that got the astronauts to the moon and back were that, they're laws, they're immutable, gravity and power. That wasn't enough for Buzz Aldrin. He needed an acknowledgement of awe and connection and mystery. That's the language that clinical science doesn't have, and that you already have. So already doing what you do does a tremendous amount to prevent mental health problems by enacting celebration and responding to suffering. And then, if you're there after we've done the treatment, you'll help someone sustain recovery. Someone's going to not relapse and drink again if they've got a community to be part of. It's much less frequent. I'm not going to have my depression return and even schizophrenia if I'm part of a connected community. And we know this from one of the primary theoreticians of suicide. He said there's three things that happen. You feel a sense of thwarted belongingness. You can't connect to folks. Or you feel like you're a perceived burden. You're not useful to anybody. You're a problem. Now, each of those things, religious congregations have, just by being themselves and being welcoming and opening, my perspective, do great interventions. And the third thing that Joyner really uncovers for us is, has someone acquired the ability? One of the reasons we worry a lot about veterans, suicide, death by suicide among veterans, is if they've been boots on ground, they've experienced a lot of harm. They've had to harm themselves. That can also be true of sports people. And that's also true of people who cut themselves. If someone's already found a way to harm themselves, that's a lot more worry. And now we're talking about a clinical need, right? We're not asking clergy to stop there, right? So what I need, again, for you to understand how much you're already doing as clergy. And then, of course, there's a point where the expertise, you need to cross a bridge to different expertise. So in community, you can nurture and protect belonging and well-being, connection and support. In the clinic, we're going to treat to restore, right? This is about well-being. In the community, you can nurture and protect it. We're there to treat it so that we can restore it. And then the real work happens. Where if we're working together and we've bridged connections, we can have sustained recovery. We can promote well-being. We can use our different abilities together. And again, we've not built anything new. We've not had to fund a building. We don't have to pay for heat. So there's three core principles here. Clergy and religious communities are experts. And clinicians are experts at different things. And that we're going to help more people if we can acknowledge this continuity of well-being, support, treatment, and recovery. And I know that you guys are busy. The clergy are busy. And everybody wants to knock on your door and tell you, you know what? Would you help us promote colonoscopies? Because you know that would get rid of cancer and that would be good for your people, and on and on and on. Because unfortunately, too many people have watched, British television where when you ask, what does vicars do? Well, one part of their day is practicing the organ, and another part of their day is arranging hymn books, and then there's the other stuff, right? So if you just watch British television, you assume that the ratio in the murder mysteries is somewhere around that, practicing the organ, and whereas you all know that in fact it's more like that. Because someone's telling you that the roof is leaking, and someone's telling you that you got a plan for, you name it, and people are calling, and you're also trying to develop community relations and a host of other things. In fact, there was a sociologist named Blizzard who came up with 6 categories of things that clergy do, which was then adopted by the Joint Commission that looked at mental health and religious congregations back in the 60s when John F. Kennedy promoted community mental health systems. So really quickly, you see that the ritualist, pastor, preacher, teacher, organizer, right? Way more than practicing organ and arranging hymnals. And we asked psychiatric patients what they wanted their clergy to do of those 6 possible things. First thing they wanted more than anything was to reduce stigma, to have their congregations acknowledge that mental illness is real. After that, they weren't looking for their clergy to be their counselors. They wanted their clergy to be clergy, to pray with them, to include them in the services, to provide social support, to give them some counsel to contact. And these are psychiatric patients who were not well-to-do. They were not looking to get financial help. And in fact, we would give them money as being part of the study, and they asked if they could give it back to their religious congregation. So what we've done is we've said, all right, let's make a vocabulary so we can divide this up. And I'm going to fly a little bit so there's time for questions. But one of the things is, again, obviously all of these overlap, but if we can give acknowledgement that there are buildings where religion takes place, and then if we put spirituality in the context of our relationships, then this is the thing that people just don't talk about in public health. We can talk about personal faith, because that's when I converse to people and they say, why did God do this to me? Just as they say to clergy, why did God do this to me? And that's a conversation around their faith. Specific to individual. Religion happens at the individual level, at the social level, and at the structural level. And there's a set of questions that we ask as clinicians, that we train people to ask, just 4. We ask if faith is or ever was part of someone's belief system. We ask how important it is and if it has an influence on their life, right? These are all things we need to know if we can engage this for hope to have them be engaged in care. And then is there a community who we could call on? And finally, do they want that? Because they could have all the above, but they really don't want us making any phone calls or making any bridges, and that's fine. And so then the question comes when someone with a mental health problem, the first question you ask, Todd, is there a way to do a quick assessment? And I can provide this to folks. This is something developed by a friend and colleague, Jamie Ayton. They have a whole spiritual first aid curriculum that they teach, as well as helping out congregations. And anybody could sit and do just with all you're doing is a check. How are you feeling physically? I'm fine. Right? I don't have an urgent need. How are things going financially? They're tight. And actually, if you can help me pay my electric bill, I can put food on the table. So it's urgent, but it's not about emotionally how you're doing. And Spiritually, how are you doing? And at a certain point, someone could say, there's no reason for me to keep living, right? And that becomes a safety concern. And it is not the job of clergy or even many clinicians to deal there. That's why we have 911 and 988. But this is a way to kind of organize a conversation when someone comes with serious mental health or what seems to be serious mental health difficulties. And so this is something you can jump right into. But in other words, we can talk more about it. There's training for this, but just so you know, spiritual first aid, this is designed to be something that happens in the congregation so you can organize how to talk with someone.
Glenn, that's great. I'm going to put the link to that website
Yeah,
in the chat.
great.
We've got about 1 more minute before we need to open it up to
Right.
questions from the community.
It looks like this.
Yeah.
This is what it looks like, folks. You've got the community, you've got the clinic. That's where the well-beings happen. If there's stress, you give connection support, people get better. If they don't get better, they need professional care. If it's dysfunction, then they go to a clinic and they get treatment, and then the recovery has to happen in the community. And when we talk about mental illness and substance abuse, it can be very severe and chronic. So you need intensive treatment and you need reintegration. And what happens best is when we can build a bridge so the two things don't wonder where the other is and know that they can work together. And then you've got community engaged collaboration, and we're all working together and people stay better longer. That's what that looks like. So thank you.
Glenn, this is awesome. Thank you so much, because what I love about this is, on the one hand, you are not telling clergy and religious leaders, hey, you need to be a mental health clinician in
Oh,
addition to
no,
being a
no.
spiritual expert.
Yeah.
And I felt like I've seen models where pastors feel like, oh, I need to go get a master's of counseling or get
You're
my
over here.
OPC.
Do what you do. Do what you
And
do.
that's what I love about this model. You're saying, be who you are, lean into the strengths of celebrating, helping people walk through grief and suffering, connect people to community. Be who you are, let
Yes.
clinicians do their thing, but know, just by being who you are, you're helping literally the public health of your community. I think that's beautiful.
And look, the boxes are sized very particularly. We're the small box. The clinic's the small box. And the
Yeah.
stuff that gets made into movies is just a very small group of people who are suicidal, who have, delusions and things like that. Day in, day
Yeah.
out, do what you do. Yeah, go ahead.
I love that. So what I would like, excuse me, Glenn, if you don't mind unsharing your screen so we can
I'm
see
sorry, lots
everyone
of
as a
it.
panel.
Yeah,
I would love to open this up for questions.
very much.
I see Lynn Hargrove, you had a question. Would you like to verbalize that? I would love to hear.
It may end up being answered in the spiritual first aid community. But what sort of symptoms should we be looking for? And how do we discern when we need to refer somebody?
First of all, I would argue. So are you a congregational clergy
I
or lay?
manage the regional office.
Yeah. So part of what goes on is, someone in a pulpit day in, day out is talking to families, talking to people, having conversations. And some of those conversations could get weird, right? But they're still not worrisome. And the first statement is, when you feel worried, follow that worry, right? Because you actually are an expert at human emotion, human thought, human function. You marry people, you bury people, you see families every week doing some of the worst behavior and best behavior, at a funeral. You watch family dynamics. You don't have to label it. You just go, wow, this is what happens every week. Sometimes it gets to this, and when it goes here, let me, now what regional offices and others can do is try to start to build well, some of you'll remember a Rolodex, right? A database of who out there has gotten some training on being able to be familiar with religion and spirituality, they don't have to share our religion. They just have to acknowledge that it's a part of someone's life. Um, and so it's more building these bridges where you've got people you can make the referral to. I don't worry so much about clergy knowing when or needing to be trained when. There's that matrix that I showed you where you can fill it in, but that's just to confirm what your gut is already telling you. Because if you've been a clergy for 3 years, you've seen hundreds of people in the full spectrum of emotion. Lynn, is that helpful and fair, would you say?
Yeah, thanks, Glenn. I see Dio. Do you have a question?
I guess, first of all, thank you. I'm Dale, a pastor from Uganda. I don't know if you're hearing me. Yeah, it's nice.
Mhm.
Do you hear me?
Yes.
All right. So, yeah, I just want to ask you the fact that, first of all, comment about that here, the needs of the people in Uganda or in Africa or in other nations other than America and maybe Europe, which are developed.
Mhm.
They have contributed much to the mental health issues among the church members. And one major cause also is the church leaders or the pastors giving the false hope to the believers, especially those who come to church with problems. And the pastors tend to pray to say they will pray for them and problems will go. And the problems keep hiking, which has almost led many believers get exhausted in faith in Christ Jesus, and many are in hospitals. And when you go to psychiatric departments, you find many people there who are religious, who are from churches, and also another challenge we are having is a lack of education of pastors. And they tend to ignore real life, and they think that the prayer will work because they don't have the knowledge. They don't have the knowledge. They are not educated.
Right. It is
So
the,
those are, yeah.
yes,
So I don't know how also that, but that's what I wanted to say anyway.
right.
Yeah.
And so one of the ways we engage that is to say, look, we're not, our question is, do you see that the person is in pain? And at that point, do we acknowledge that we want to help the person's pain? And so from a human perspective, we want to reduce someone's pain, so let's use every resource we can. If the person had a tumor, you would go to an oncologist. If I tell you there are clinicians who can help with the hallucinations, I'm not telling you that your prayer won't help. I'm telling you I've got even more tools. This is not a test of any God. And on a theological side, it's like, wait a minute, who are you to tell God when to do the healing and to deny any other resource that's possible? So it's complicated. There's a lot of ego that can be involved. And you are right that if we do not give people all the care they can, but rather than say this is good or that is bad, rather just look at all the different possibilities for relieving the person's pain. Let's use it all. And you can go there. It doesn't mean that a stubborn person won't be a stubborn person. That's the way to offer it, not as a challenge, as a help, because we all want the pain gone. I hope that helps, Dale. I hope you can hear me.
Thank you, Glenn. I think we have time for one more question.
I have mine is not a question per se, but I am both a chaplain and a pastor.
Right.
So sometimes when you want to refer people, they look at it as let's say I'm referring you to a clinician or to a psychologist. it's like you have already said I am mentally ill.
Right.
You have diagnosed me. You are not a doctor. So how best then can I, as in the hospital, I know how to do it because there's HIPAA that helps me this and that, this and that. But
Yeah.
at my church now, when I have talked to my family members, to those whatever is going through, can I only tell them to go to the ER? Oh, can I tell them to go to the clinician? Because by the moment I tell them to come to you, I have
Mhm.
already told them that they are mentally ill. In my culture now, as an African person,
Yes.
that's
Yes.
terrible to
Yeah.
tell someone that you are insane by just telling them to go to
Yes.
you.
And so again, so first of all, do you know mental health clinicians who you've worked with, who you could make a referral to?
I know those in the hospital because I work at the hospital. So
Right.
I know where people are being referred. Yeah.
And some of those people have private practice, have their own.
Yeah, some have.
Yeah. And so now again, they've come to you because of pain,
Mhm.
and just as if they had a broken leg, you have a friend who has a degree who can help with pain.
Yeah.
There's no diagnosis. And that's the other thing that, that Lynn was asking about. We're not training clergy to be diagnosticians. We're training clergy to acknowledge the expertise you already have in different levels of people's pain. And so the recommendation is to say, I have a friend who I trust, who has some other things to help with this pain, and we need to do that. And it doesn't have to be, unless they see psychologists and they immediately are insulted,
Mhm.
then at some point we have to have humor here and say, you can stay in pain,
Mhm.
or, the other way to talk about it, which is from Ecclesiasticus, that says God made the physician.
Mhm.
Are you going to deny the creation of God to help you reduce your pain?
Hmm.
Now, culturally, yes, it's the biggest insult. It's the biggest stigma in many cultures. And so we have to work around it and bring it into the whole clinical space and also friend space. What'll matter in your church is that it's a referral to someone you know,
Mhm.
and it's in the service of reducing pain. And because you know this person, they're part of the big plan, I think is fair. What do you think? All right.
That's fine. Yeah.
Let
Thank
us
you.
know. Let us know if that.
Thank you very
Yeah,
much.
that's what I think. We just, in a word, humility,
Yeah.
you know?
Irene, I think that's a great question.
Yeah.
I'm so thankful you asked that. Thank you. What I'm gonna do is I am gonna actually, um, in the chat, I am going to add the PDF, um, of, um, hold on just a minute. Oops, I accidentally sent it I didn't send it to everybody. I'm gonna add the PDF of Glenn's, um, COPE model, his publication, to the PDF, so you have a copy of that. Um, and so that if you want to go deeper into this, there's his writing. And so, Glenn, I want to say thank you. This was great. Thank you so much for sharing your research. Thank you
Cool.
for your passion on connecting religious leaders and mental health clinicians and getting both of them connected and building those bridges, which it's not happening enough. And I'm so thankful you're one of the voices that's doing that. So I am so thrilled you shared your research, your understanding with us. And it was really great to hear a clinician's perspective. So thank you so much.
Thank you all. Thank you all.
Um,
Thank you
like I
both.
said before, our next meeting is March 9th. It's our second online one. So we try to do 1 to 2 online meetings a semester. And it's with Ryan Burge, who is the leading data visualization guru on religion. We're going to be asking him about his new book, The Vanishing Church. I'm also going to put a link in that if that interests you and you're like, oh, I want to pick up that book before we interview Ryan. Um, I'm going to put that in the link as well if you would like to check out that book. Um, and so, yeah, once again, Glenn, thank you so much. This has been so good.
Thank you all.
And if people want to follow with email, they can search your name and find
Yeah,
your
and it's
City
on our paper
College.
as well. Yeah, very
Say
easy.
that again.
It's in the paper, and yeah, you just Google Glenn Milstein. No,
Perfect.
the way to.
Perfect. Okay, well, unfortunately, we're out of time, but thank you everyone for being here. I really appreciate it. Glenn, thank you
Thank you.
for sharing your expertise with us. This has been amazing, and so we look forward to seeing everyone at future events, and to continue this conversation about how do we lead in the midst of change, because that's what you're doing. You are leading as the floor is shifting under you, whether that's mental health shifts, or demographic shifts. So thank you so much, and we will see you next time. Y'all take care.
Thank you all.